Hello, everybody. I'm Jules. I work at the Surrey Park Clinic. It's a private women's health clinic based in Guildford. And today we are talking all things menopause. I'm delighted to say that Dr Alex Standring has joined us to discuss this. And me being a 46-year-old, this is quite a relevant subject for me. So this will be great. So Alex, do you want to just introduce yourself?
Yeah, hi, I'm Alex Standring. I'm a GP in the Guildford area, and I've got a special interest in women's health, but particularly the menopause at the moment. So I've been working up at Surrey Park for a couple of years now. So
fantastic. Okay, so we've had some great questions sent in, but I thought maybe just to kick things off, if you could just start giving an overview of menopause. I'm sure lots of people know about it, but just to bring everyone up to the same level, yeah, you can just talk through.
Okay, so I mean, I'm sure most people know the menopause is basically defined when your periods stop and your ovaries run out of eggs effectively. But the run up to the menopause can take a very long time, and it's a very individual experience for people. Some people's periods just stop straight away, other people's get more frequent, other people's get less frequent, some people miss them. And aside from the period issues, the thing that people find most tricky really is the symptoms mostly really of sort of sleep disturbance and hot flushes tend to be the most common thing that people get. But there is a massive effect on all sort of organs and parts of the body. So not only do you get the sleep disturbance, you then get often low mood, people get very emotional. I mean, I think women are generally, I'm allowed to say, a little bit more emotional anyway, particularly when we're tired. It certainly makes me more tearful when I'm tired. So I think that's a big thing. And it's also the swings of emotions. It's not just the flat emotion. Obviously things like low libido and vaginal dryness and just general soreness down below is very common around the time of menopause, and actually can often develop a bit later on as well. You can get more frequent headaches, you get joint aches and pains. What else do you get? Well, that's probably enough to begin with. Oh, the other thing is, big thing is sort of memory loss and confusion and muddling, and people find that they try and go into meetings and can't remember what they're going to talk about, just like me just then. and an increase in sort of generalized anxiety and things as well. That they're very big complaints that I see.
Yeah. It's brilliant being a woman, isn't it? Oh my god,
lovely. Yeah.
just out of interest, do some people just get off quite lightly and they sail through it, and then other people it can be really extreme, I imagine?
Yeah, some people have no idea that and don't even know it's happened until they realise that, a year down the line they haven't had a period and they're fine. But the trouble with that is that, estrogen has a sort of protective effect on our bones and things. So it's not just for symptom relief, even though really that's how we're advised to treat people, is just for symptom relief, but it does have long-term effect, protective effects, particularly on your bones. So that's a big issue. And so that's the slight worry, is that people who don't have any symptoms, and then later on they can find they've got osteoporosis and things like that because they haven't had enough estrogen. So
and roughly sort of how long can the whole process take, and is the average age sort of when you sort of get through menopause, is it around early 50s, is that right?
Yeah, so I mean the average age in the UK is supposed to be 52, which means that you can start, commonly after 45 is really when people's symptoms tend to start, and can go on to 55. I mean, I've got ladies in their 60s who still, and 70s even, who still get hot flushes. And so that it can go on a very long time, and it, as you say, it can not affect you at all. So it really varies. There's no one size fits all, and just because you've started having really bad hot flushes doesn't mean they're going to continue for years and years. They might come and then they might settle down again for a little while, and then they might happen again. So yeah, it's a bit of a nightmare, or it can be a nightmare.
Not straightforward at all. No. Thank you for that. That was great. So I'll just go through some of the questions. I've tried to make them a bit more general, because obviously it's difficult for you to comment on individual symptoms. So I've tried to group them. A lot of people want to know about HRT and the differences between standard HRT and bioidentical. Can you summarise that?
Yeah, it's slightly complicated in that there's a sort of a current a move towards what people are calling sort of bioidentical hormones, which is certain clinics do, and they do sort of salivary tests and blood tests and things to try and get a specific hormone profile, and then they make the chemicals up to suit the individual. We don't do that at Surrey Park. It's not recommended by the British Menopause Society. It's not been properly tried and tested. It's not validated. There's not great scientific evidence for it. But the hormones that we use are what's called bioidentical, body identical hormones, particularly the transdermal estrogen, the estrogen that goes through the skin as a gel or a patch, is the same as the hormone that we produce, estradiol, in our body. So that is available. It's exactly the same hormone. It's been tried and tested. We know the good, we know the bad. And there's different types of progesterone that you can use. And there's one that is now readily available, called Utis, which is a micronized progesterone, which is exactly the same as the progesterone that we produce naturally in our body. So that's what we do, which is, there's different terms for it, whether it's body identical, bioidentical. The Menopause Society call it combined regulated HRT. So
yeah, okay, brilliant. And then obviously you've mentioned about estrogen and the effect on bones and moods. Other things that you've mentioned, sleep as well, or is that more to do with progesterone, sleep?
Well, generally your symptoms are improved by the estrogen. So hot flushes can cause sleep disturbance, but you can just get sleep disturbance without having the hot flushes. Again,
that's where I'm at the moment.
Yeah, thought to be due to the sort of low or fluctuating hormone levels. That's often the cause. So estrogen helps with hot flushes and sleep, but it sometimes just helps with normal sleep too. The progesterone is really to protect your womb from the effects of having estrogen. It doesn't cause really any symptom relief, although having said that, the Utis, the micronized progesterone, is supposed to help with sleep and also a little bit with anxiety as well. You take it at night, it's supposed to improve the quality of your sleep. But generally the reason you have a progesterone is to protect your womb from the effects of estrogen on its own. So you have to have both if you've not had a hysterectomy, or you've got a Mirena coil, which is another way of protecting the lining of your womb. So
right. Okay. And then does estrogen help with like collagen production and things like that?
Yeah, I mean every part of your body pretty much has an estrogen receptor in it. So you know, our brains, our skin, our muscles, our tendons. So there is after the menopause, there is, I think it's about a 2% loss of muscle, even if you exercise, if you haven't got estrogen. Whereas if you take estrogen, it helps you. So your muscle mass will, as you get older, goes. But if you haven't got extra estrogen, it really goes much quicker. So yeah, it is everywhere. And obviously collagen in your skin and things. So
yeah, and I suppose some of the concerns are, you know, there was a risk with HRT and cancer or breast cancer. How is that now, that risk?
So it's quite complicated because they keep sort of revisiting the research, and the latest scare that I think was in October, I think it was the Lancet that did a review of all the papers, and they took not only published papers, but they also looked at papers that hadn't even been published, so the results hadn't been ratified and things. And I think what I always say to people, there is very little doubt really that estrogen and progesterone increases your risk of breast cancer. It's not a dramatic amount, and the numbers, as I said, I think, you know, whichever study you read, they seem to vary, but it's a pretty undisputed fact, really. There's some very good statistics and patient information leaflets on a website called Women's Health Concern, which has got some good infographics about raised rates and things. But basically, your rate of increased risk of breast cancer on HRT is much the same as if you drink more than 2 units of wine or alcohol a night, or if you're very overweight. So it's a risk, but it's not anything out with some people's normal background risk.
Right.
And if you take estrogen on its own, there is some good evidence that actually that reduces your risk of breast cancer. So you are more likely, if you're on combined HRT, estrogen and progesterone, to get breast cancer, but you're no more likely to die from it. So that's the thing that's a bit frustrating about the studies, is that they don't emphasize the importance of estrogen for reducing mortality overall. So your breast cancer mortality isn't increased, but you are more likely to get it. So if you have most people know somebody who's got breast cancer, it's a really big worry, but I think you have to balance the breast cancer risk about the benefits on everything else, like the bones. If you start it earlier, it's got good cardiovascular protection, your general well-being, the fact that you can go to a meeting and remember what you say, your relationship is better because you have a better sex life, you're not a nightmare to live with because your hormones aren't making you go crazy, you sleep better, you feel better, all the other things are very much underplayed, and they think there's a reduced risk of bowel cancer, and also probably, although again there's not very good evidence for it, dementia. So much good stuff.
Yeah.
And at the moment, really, the main bad is the breast cancer and endometrial cancer if you're not careful, but and a bit possibly.
But those statistics are fairly low.
Yeah, I mean, it is a significant increased risk. So I have to always check the figures, but it's something like 4 or 5 per 1,000. But again, it depends which study you look at. All the studies have different figures. So, the British Menopause Society and Women's Health Concern are producing some infographics for that, so that people can actually look it up.
Well, I'll tag that website onto the post.
Yeah, it is a very good one.
Okay, brilliant, thank you. And testosterone has been mentioned. Do we? Obviously, that comes across as a male hormone, but I know that we all have testosterone, don't we? Is that right?
Yeah. Our ovaries produce testosterone, and obviously as we go through the menopause, we produce less, and the balance of estrogen and testosterone varies. But a lot of women benefit from testosterone. Not everybody needs it. I generally get people sorted out on their regular HRT, their estrogen and progesterone, and see what effects it has. And often that's all you need to help with your libido and the vaginal dryness and discomfort and things. But if you're on a fairly reasonable dose of that and still getting symptoms, then I quite often would add testosterone under certain circumstances. The problem we have in this country is it's not licensed in women. There's no preparation that's approved for, it's not licensed for use in women, but it's accepted that it's, by the menopause that we can use it in women, but it's not licensed, so that makes it a little bit trickier. You have to monitor it, you have to take blood tests to make sure that the levels are right and things, but there's no evidence really of long-term harm from using it. Minor side effects at the time, but nothing long-term.
Right. Okay. I think we've talked about progesterone. One of the final areas really that people are talking about is bladder weakness and increase of UTIs. They relate to the menopause. Yeah,
definitely. There's a lot of one thing we didn't really sort of cover is that on the base of the bladder there are a lot of estrogen, and just lacking estrogen just causes the bladder irritability. And aside from the sort of vaginal dryness and the discomfort, which tends to increase the risk of UTIs as you get older as well. So that's another good point for taking HRT, although some women actually need vaginal estrogen as well as oral or transdermal HRT, because again, the effects are very individual, so you can still be on a fairly good dose of HRT and actually still have significant dryness and discomfort, in which case it's easy, you just add some topical estrogen. But certainly bladder irritability and getting up at night to go to the loo, partly because you're awake because you're not sleeping very well because you're having hot flushes and partly because you need to go to the loo, so it's a great combination, and it definitely helps with all of that, and particularly that sort of irritability and that sort of sensation.
And bladder weakness, is that because maybe for people who aren't on HRT, the lack of estrogen makes your muscles weaker?
I mean, it's complicated, and it's not just estrogen. As we get older, and if you've had babies at all, even if you've not had a vaginal delivery, your pelvic floor is weaker. So there's different types of bladder weakness. There's sort of the stress incontinence where you cough and sneeze and dance and have a little accident, or more the sort of irritability and the urgency where you have to run to the loo very quickly, you can't hold on to it. And it's a combination. I mean, generally the sort of estrogen will help with that, but also, if you've got stress incontinence, you need to do pelvic floor exercises. That's the main thing, is to strengthen the muscle, but having the estrogen helps with that too. So it's a combination.
Right. Okay. Well, that's all one pressing, isn't it?
The other thing I didn't really mention is the Myarina coil, which is another way of getting the progesterone instead of having it by a tablet or a patch. And there's loads of different ways of having your HRT. So the estrogen bit comes in either a patch, a gel, which are in theory the safest ways, because there is a lower risk of blood clots and thrombosis if you take it through the skin. But you can have it as a tablet, you can have it as a spray, and then the progesterone you have to have, as I said, to counteract the effects of the estrogen on the womb, and that has a tablet or a patch as well. And then there's the Utis, which is a slightly different one. And then Myarina coil is a very good way of having it, because it's basically a coil with progesterone in it, and it sits inside the womb, and it basically just works locally on the womb, so you don't have any sort of systemic effects from taking the progesterone, because some people find progesterone quite difficult to take, and it can make them feel really unwell.
Right.
Just called progesterone intolerance. It can be a problem. But if you take the coil, it basically protects the lining of the womb. If you're having erratic periods or heavy periods, which people often do approaching the menopause, it sort of sorts all that out. And it also sorts out contraception, because when you're approaching the menopause, you were still fertile, obviously a lot less, but really your fertility continues until, if you're over 50, a year after your last period, which is potentially quite a long time. And you have to have, because the HRT doesn't work as contraceptive, so you have to have something as well as that. So that's why the coil is so lovely, because it does everything. It sorts your womb out, gives you contraception, and it protects you from the estrogen.
Yeah. Okay. And so if someone was coming to see you, and if they chose to take HRT, would you see them, and then do you monitor it? How do you know it's sort of the right levels?
I don't always do blood tests. I do with testosterone, but I don't always do estrogen levels unless people want it. To start with, by definition, if you are having menopausal symptoms, your estrogen levels are going to be low, and you are likely to benefit from some estrogen. But the nice thing about working in a private clinic is that you can monitor it much more easily. It's not done so much in the NHS, just because tests are expensive, and a lot of GPs don't have enough experience with it. But so we will monitor according to response, really. I tend to do it, and every so often, if it's appropriate, I will do blood tests, just really to make sure that the doses are right, and that sometimes people have trouble absorbing estrogen through the skin, and a patch doesn't work as well as a gel, or vice versa. So it is nice to know that you're having an effect. And as I said, testosterone, if you to monitor that anyway. And we can do scans at the clinic if necessary. Again, it's not something I would routinely do, but if there's any doubt, it's easy to do, and to just keep an eye on, make sure that everything gynae wise looks okay. So we would basically do an initial appointment, which doing a lot obviously on the phone at the moment, or Zoom, and it's nice if people have got their blood pressure and things like that before I speak to them, but it's not the end of the world. And then we would generally, in a normal situation, review in about 3 months time. If it's a first prescription, make sure that you haven't got any side effects. You often get a bit of bleeding when you're starting it, but just to monitor all of that. And then once people are happy and sorted, it's a yearly checkup, and you stay on it really as long as you need to, as long as you want to, and as much as the latest scare comes and puts everybody off it again.
Yeah.
Is what's to do.
Brilliant. Okay. And obviously there's some people that just won't want to take HRT, or can't take HRT, possibly for medical reasons.
Yes.
So are there any ways that they can help with their symptoms, or is there anything that they need to be thinking about and looking out for?
Generally, so keeping fit, exercising is really good for both premenstrual syndrome and menopausal symptoms. Seems to have quite a good effect on that. And there are a lot of sort of herbal things that are recommended, things like black cohosh and red clover, phytoestrogens and soya beans and edamame beans and all that sort of stuff. I think, obviously I see the people that who that hasn't worked in, because otherwise they wouldn't bother to come and see me. But I think some people do find it effective, a lot don't, which is why they come for the HRT. And again, it's a little bit like this sort of, so-called body identical hormones, or bioidenticals, or whatever they're called. It's not, the herbal things haven't been tried and tested in quite the same way. We know some potential risks and things with them, but generally, that HRT has a lot of scientific data behind it. So yeah, it's not all good, but at least we know pretty much what the bad things are for it. So yeah, I mean, lifestyle generally, and keeping down alcohol and caffeine for hot flashes and things like that, and bladder irritability as well. Exercise, low GI diet, so low carb diet's quite good, again because of the effects on sort of insulin and hormone levels and stuff. It can help. So often just recommend things like that. But there are alternatives that you can take for hot flashes, so particularly ladies who have had breast cancer who can't take HRT. There are certain other medications that are prescribable along the sort of antidepressant line, which are used not as antidepressants, but because of the effects that they have on people. So there are lots of options, and most people can also take vaginal estrogen just to help with that.
Gosh, you could talk and talk and talk about this.
And that's why my appointments are so long.
Well, I really appreciate you taking the time out to talk it through. So thank you very much, and take care, everybody.
See you next week. Yeah, bye.
Bye.